You're listening to Psych with Mike. For more episodes or to connect with the show with comments, ideas, or to be a guest, go to www.psychwithmike.com. Follow the show on Twitter @PsychWithMike or like the Facebook page @PsychWithMike. Now, here's Psych with Mike.
Welcome into the Psych with Mike library. This is Dr. Michael Mahan. I am here with my good friend and colleague, Mr. Brett Newcomb.
Hello.
So in real time, we are doing this. It is around about the time of Thanksgiving. So did you get filled up on turkey?
Not yet, but I will have by the time this airs.
Okay. So you're telegraphing our play that we're actually recording this before Thanksgiving, but by the time people hear this, we will have had our turkey and pumpkin pie and be rightfully thankful for it.
Amen.
So we're going to talk about a subject today that we haven't touched on yet in the podcast, that is actually a very sobering and very real and emotionally intense subject, and that is the subject of self-harm.
Yeah, I actually read an article this week that said one doctor kills himself every day in America. And just the article is talking about how doctors experience depression as a substantial part of their reality, the difficulties, the things they have to deal with. And it said 44% of 15,000 doctors surveyed, 44% of them reported that they are either, and the word they used was cognitively depressed or clinically depressed. So I'm assuming that cognitively depressed is when you just say, God, I'm really depressed.
Yeah,
and
situational depression
is when you're on medicine for it, getting treatment for it. But that as much as one doctor a day kills himself. So then I started thinking about the number of suicidal clients and people that I've talked to, encountered, and then that led me to think about, before we got to that level of severity, the number of people that I talked to who self-harmed, and what I understood about that, what I was taught about that, and how that works, and it's a fascinating thing to study and to learn about, and you want to do that not because you're pruriently fascinated, but because it's really important. There are an awful lot of people who self-harm,
right? And
so I mentioned that to you, and you said, "Well, let's talk about it."
Yeah, and I would even argue that any therapist who says, "Oh, I don't do a lot of that work," is
less qualified than you think.
Well, I don't want to say that, but yes, there are people in their practice that engage in self-harm, whether they're aware of it or not. Just like when people say, I don't do a lot of substance abuse work, if that's the case, then you have people in your practice that are substance abusers, whether you identify that or not.
I remember how surprised my students were over a 25-year period at the university when I told them, if you're doing an intake interview with a new client, you have to ask them, are you a sexual abuse survivor? That's first, not the very first question you ask them, but in the first interview. To set the stage for saying, if you are, it's okay to say that, because we can talk about that. We can deal with that.
And I do
that's fine too.
I do a more global presentation. I ask if there's trauma in their history, and not so that they will talk about it, but so that it lays, just as you're saying, the foundation for that is an okay, comfortable, safe subject. May not be comfortable, but safe subject to be able to talk about, because they may not talk about it in that first meeting, but then, down
they may not know about it. Very often their defenses block them from knowing, and then as the therapy works and their subconscious gets stronger, they get healthier, then they'll have some of these flashbacks or memories that say, oh my God, I think this happened to me. And you don't have to prove whether it did or didn't. You can say, well, let's talk about those feelings that are flaring up inside you. What do you remember? How do you feel? And you normalize it in the sense of saying it's okay and safe for you to know the truth, whatever that is. And so to go further back, the question then of self-harm. Do you, for instance, are you a cutter? Do you cut yourself? Do you, and when and under what circumstances? What are you aware of feeling when you do? What, or before you do, or after you do? And just process that whole thing as if it's not shocking. It's not, oh my God, I can't believe you do that. But so let's figure out what that's all about.
And to also then help the important people in that person's life understand what that's all about, because I tell people,
especially parents, we're usually talking about teenagers. This is a much more common phenomenon among teenagers.
Absolutely. Yeah. Although I do have adult women and adult men who have engaged in the behavior, but most of the time,
it's a lower percentage of the population.
We're talking about teenagers, especially when it's first acknowledged. It's usually in the teen years, and people will say, well, I just don't understand this, and I would tell them, human beings don't do anything unless there's a perceived benefit. None of us engage in any behavior more than once unless we get some perceived benefit from it.
Well, and I mentioned cutting, and cutting is one of the more common experiences of that, but it can be anything. I've had clients that in times of stress will take an ink pen and shove it into their palm because it's somewhat discreet. If they're in a meeting or something, they can do that. And the pain signal that they receive hyper focuses them away from the anxiety or despair or whatever negative thought that they were feeling.
That's right.
And allows them to shut that out for a momentary gain.
And anybody who knows me, anybody who's seen me on camera, or anybody who's ever done therapy with me knows that I have a pen in my hand 24 hours a day, 7 days a week, which actually is something that I learned from you.
Yeah, well, it's a phallic thing.
You say that, but it isn't. And when I do therapy, I tell people, I joke about it all the time, but it's actually true.
Right.
I can't do therapy without a pen.
Right.
And if I don't have my therapy pen, then, we're going to be in trouble.
What it is, it's a channel.
It's a tactile stimulation.
Drains off the interrupters for your ability to pay attention to what's going on.
It's a grounding mechanism.
Yeah, absolutely.
Which is what cutting is, or any other form of self-harm. And people don't recognize it because from the outside, you would say, how could something self-destructive be positive for the individual? Well, just because you don't understand it doesn't mean it isn't positive for them.
Yeah, that's an interesting perception.
Right.
Yeah, no, I agree.
But it is a grounding mechanism, and for a lot of people who recognize...
This is how I stay in my skin. I'm terrified. And this will help me feel pain that blocks the momentary feeling of terror. And hopefully then I can ride through this encounter and feel better afterwards.
And so it doesn't matter what the behavior is. People, and I've seen this when I was in the hospital. I haven't seen it in private practice, but I did see it when I was in the hospital. Somebody who would turn the stove on and put their hand flat on the burner and hold it there. And people would say, oh my God, that is insane. Why would anybody do that? Well, for that individual, that behavior was perceived, at least, as being beneficial.
Well, for instance, I'll show you how old I am. I remember in the Watergate era, G. Gordon Liddy, who was one of the original Watergate burglars, used to torture himself, teach himself to control his reaction to pain by holding his hand over an open candle flame, literally until his skin burned black, and would force himself not to react to it, and would teach his body to control that response to pain. That then would become a focusing mechanism in case he were interrogated that would help him endure the interrogation and not give up the baby, whatever information they were trying to get from him.
Right.
So we're not advocating that as a skill set that you should learn, but we are trying to understand that process and behavior for people who've learned it incidentally.
Because when somebody who has this as a coping strategy in their toolbox ends up hearing from another person, wow, okay, I understand, that's a grounding mechanism. All of a sudden, it is elucidating for them. It is so freeing. And that's what I want to say to the significant others is, as long as, because what people are used to hearing or the reaction being is, oh my God, startled, almost terrored, oh, that's crazy. How could you do that? Oh my God, I feel so bad for you. When they have somebody who is able to sit in that room with them and say, okay, I understand, that's a grounding mechanism. They're like, oh my God, you get it.
Yeah, and then you can talk about what do you need grounding from? What's going on in your life that causes you to feel this? And are there alternative things that you could do that don't harm you? Because this is a payoff, it's a positive for you, but it's ultimately harming to you. So what do you know about what's going on, what you feel, what you think when you get the urge. How early in the process does the urge come? Do you anticipate it like 2 days before a final exam? Or does it just happen in the immediate moment, like you have an argument with your boyfriend?
Mm-hmm.
And then as we learn how they process these things, we can begin to talk to them about interrupts. Can we stop before this point? Or when this trigger gets established, can we stop before the next trigger?
Mm-hmm.
And so you can begin to work with them on their ability to have more control,
mm-hmm.
which is part of what the grounding is all about.
Mm-hmm.
And you can help them understand what they're doing,
mm-hmm.
what the payoff is, because everything that you do, every choice that you make, every behavior that you have, pays and costs.
Mm-hmm.
So we want to teach emotional economics. Can you afford the cost of your choice?
Mm-hmm.
Is there a better choice? Or is there a different choice that would give you a better payoff?
Mm-hmm.
And so you're looking for a window or a door to open and get into the internal process that's causing them distress and pain.
Right. And so there are a couple of therapies that are acknowledged as being really beneficial in this area. So dialectical behavior therapy is one, and then EMDR, or eye movement desensitization, is another.
Right.
And dialectical behavior therapy is very similar to cognitive behavior therapy, but with a focus on mindfulness. And so that's exactly what you're talking about, is becoming more mindful of what the triggers are and trying to find opportunities to be able to intervene in those trigger evolutions, so that the person can then try and mindfully be able to select alternative behaviors.
Well, yeah, it's the cognitive behavior or dialectical behavior process is based on a philosophy that structures logical reasoning arguments. And they say that if you take a thesis, any thesis in the world that you want to establish, God is good, then you take an opposite thesis that's called the antithesis. And so people get stuck on the horns of a dilemma. Here's what I want to do, but this is what it's going to cost me. It's painful. And you try to create a synthesis which merges a little from each side and brings it to a model. And so Lenin and I'm suddenly going blank. Dialectical materialism was a theory of history about capitalism, ownership, the opposite,
Marx.
Slavery. Yeah, Lenin, Marx, and Engels. And then the synthesis would be socialism. So they were trying to control history by controlling what would be the thesis, what would be the antithesis, and predict what would be the synthesis. So they were predicting the future curve of world progress. Didn't work out that way because they didn't factor in for human nature. So that whole from each according to ability and to each according to need doesn't really work out when you're talking about human beings. But the concept of the thesis, antithesis, synthesis can help people who are feeling extreme options in their life grasp the idea that there could be a middle way. There could be a way forward that then could become a new thesis.
Right.
Then there would be a new antithesis that would develop, and then a new compromise. And so progress can be envisioned, and they can be empowered to move towards the progress.
So I'm a big believer in the idea that if you create a vacuum, you have done a person a disservice. So I tell people, don't ask somebody to stop doing drugs unless you're going to fill the void, because nature abhors a vacuum. Something's going to fill the space. And so when we are talking to individuals who we are saying, could we come up with a way of intervening in these trigger events and try and choose different behaviors, we have to give them some alternative for what the payoff is for the self-destructive behavior. So if the self-destructive behavior is one of grounding, then we have to find alternative ways of being able to help that person self-soothe or ground.
Yeah, I know a couple of people that have given up cutting in favor of getting tattoos. And they decorate their body artistically or symbolically, either one.
Right.
And the process of getting the tattoo, which these people that I'm talking about get a tattoo whenever some significant event happens in their life, and usually negative significance. And others do it when a level of tension develops to the point that they know they're going to start cutting. Instead of cutting, they've chosen to get another tattoo. And tattoo is more socially acceptable now than it was 35 years ago. So more and more people have them. and you see people that have their whole body covered in work, like tattoo sleeve on the arm, and every inch of skin.
Ray Bradbury's story, The Illustrated Man.
Yeah. So, I mean, and I'm not suggesting that as an alternative that would work for everybody, but it's a synthesis that has evolved out of this dialogue for these individuals.
And I don't do EMDR, and I don't think you ever did.
I never did
EMDR.
it. I read about it and studied, took a class in it, but didn't practice it.
And so if there's anybody who is listening to this that does EMDR, I would love for them to get a hold of us, because I would really like to have someone who has some significant grounded experience in EMDR come on the show and talk about that with us. But one of the things that I have learned in my study of EMDR, and again, I don't do EMDR as
You're not a practitioner.
Right. Yeah. But I do believe in a lot of the grounding that EMDR is about, and specifically the bilateral grounding. And so I do try, and with my people who have trauma histories or have a self-harm background, try and help them to find alternative grounding mechanisms. One of the things in EMDR that I really like, that I was taught by someone who is a practitioner, is something called a butterfly hug. And so a butterfly hug, if you can see me on the camera, I have my thumbs intertwined and my fingers splayed out as if they were the wings of a butterfly. And you place that over your heart, and you tap with your fingers on both sides of your chest, just below the clavicle. And that is a grounding technique in EMDR. It's called bilateral grounding. So the idea is that you have to have both sides of the body engaged in a simultaneous behavior. So you can take cush balls and hold them in both hands and squeeze them. Some way of being able to create bilateral stimulation.
Well, that's what's going on with the rapid eye movement back and forth.
Yes, exactly. It's another form of that.
Yeah. So the eye movement desensitization, something that you're terrified about, snakes. I can show you a picture of a snake and you could have a panic attack. But if I could teach you to envision seeing a snake while you're fluttering your eyes back and forth like that, we can teach you to learn that behavior can quiet the fear.
So it's all about, though, trying to help an individual to compensate for that lack of self-soothing. So what this really is at its core is that the individual hasn't developed a comprehensive set of skill sets that allow them to self-soothe. And so they engage in this self-destructive behavior as a way of remaining grounded. And what we have to do as therapists is to give them alternatives, both to understand when the triggers are coming and then behaviors to engage in to try and keep themselves grounded so that they don't have to do something more self-destructive.
Yeah, well, it's hard to begin that journey of identifying what your triggers are, because if you start sneaking up on what's the trigger will set off.
Exactly.
So, how can you get just short of that and start to feel that first surge of panic or anxiety, whatever it might be, pain, and then stop? So
in dialectical behavior therapy, and again, I don't do this as a primary therapy, but I know one of the techniques that they use is to say, on a scale of 1 to 10, how nervous are you right now? Okay, I'm a 3. Okay, well, we're going to, do an imagery exercise. If you get to a 5, I want you to let me know, because I don't want to take you beyond a 5. And so let's then, because we're going to approach it. Now, today we talked about, for people who are sexually abuse survivors, he was entering the room. I feel a 7. Okay, we're stopping.
Right.
Okay. Then the next time we do that, we might talk about he was entering the room and you might only be a 6. And so the idea is that we're going to try and work our way through that without actually getting to the point of triggering. But while, when we do that, okay, when you start to get ignited, then we're going to do something like the butterfly hug or something to help keep ourselves grounded. And the idea is that then we can get closer. It's asymptotic, right? So we always get closer to never crossing the line of being triggered. But that's the whole goal, because you're absolutely right. What we don't want to do is to set off a full-blown panic attack.
No. So this to me illustrates one of the differences between us. You are fascinated by the terminology and the ability to articulate the science behind the terminology. I just want to know, does it work? And so I don't know if it's Reichian body work, if it's tapping, if it's butterfly asymmetrical. I don't care. I just want to know, can I find a strategy that helps you identify the trigger and stop just short of it and give you the power of being in control of that so you aren't swept away in things that are self-destructive to you.
Well, and my hope is that is why we are good at this and why this podcast maybe is beneficial to people, because there are people who think like me and there are people who think like you, and hopefully we can present both sides of that understanding coin, and that is beneficial to individuals.
As long as we always remember which approach is the better one.
Yours.
Yes, of course.
Simple is always better. That's what I've been told in science.
KISS principle.
Yeah,
that's right.
Yeah. Well, it's Occam's razor, isn't it?
See, I love that about
the simplest explanation.
I know that.
Okay.
Yeah.
So let's land this airplane. For people who either are using some form of self-harm as a grounding technique or think that they know someone who is, we would definitely encourage those individuals to seek out a supportive environment, either a group of individuals, because there are groups for individuals who engage in self-harm, or to call a therapist. If you're going to call a therapist, I'm always encouraging people, be your own best advocate in therapy. Ask your therapist, what kind of therapy do you do? And ask them, do you have experience in this area? Would you feel comfortable working with me? Don't just assume that you can call somebody and they're going to be an expert in whatever your problem is.
It's not one size fits all.
That's right.
I used to always tell people who were hesitant, who'd been referred to me, and it's kind of like, well, who are you? What do you do? I said, come spend an hour with me. Come spend a couple hours with me.
That's right.
If it doesn't feel like it's a fit, then I won't charge you. You go away, no harm, no foul. And if it does feel like it's a fit and you want to continue, then you pay me for the visits. And they were always like, you mean I can come free? I said, well, you can come once or twice for free, and by then you should know either I'm somebody you can talk to or I'm not. And I'm confident enough in what I do that I think you will honestly know the answer. So I'll go with your decision. And I think other therapists ought to work that way.
I think, well, yes, I think everybody should work that way.
But I mean, more so than looking at a checklist. I'm a certified this, I'm certified that, I'm a certified. Go spend some time with them. I mean, I can have all those certifications and be a doofus as far as sitting in the room being a therapist.
Right. The only so this would be my reluctance in just jumping onto that bandwagon 100%, is a lot of times the real issue doesn't come out in the first therapy session. And so you know about the rapport.
Music begins.
I know. You know the rapport, and I think that is substantially the most important thing. But you could have a good rapport with somebody that then gets triggered because you're talking about things that are
issues in their life.
Yeah,
absolutely. That's always and the whole countertransference thing is a risk.
Exactly.
But my salient point is the dance begins and it's nonverbal. And if you feel comfortable with me, then even if the presenting problem is not the problem, which it almost never is, the thing that brings you in the door, we can get there.
Absolutely.
If you'll spend the time with me, we'll get there.
Absolutely. So hopefully people got something out of this. Again, if you are an EMDR therapist and would like to contribute to the show, we would love to hear from you. You can go to psychwithmike.com and get a hold of us there. The music that appears in Psych with Mike is written and performed by Mr. Benjamin DeClue, and I thank him for his service to the show. And remember, if it's Friday, it's Psych with Mike.